Dr.
Hi,
Victor,
Victor. Good to see you. Ahmed, good to see you. Pirzad, hi.
how are you, Dr. Salman? Thank you for having you.
Not bad. It's a pleasure to be here. I'm sorry I was busy during the day, so I couldn't join you earlier.
Thank you very much. I will make you a host now, so you can. Okay. Victor. Okay.
Hello, salam alaikum.
Wa alaikum assalam wa rahmatullahi wa barakatuh.
How are you? Nice
Not
to see
too
you.
bad. Good. It's a pleasure to see you always.
Okay, thank you. Thank you, sir. Shukriya. Shukran.
You're most welcome.
Thank you, sir.
Okay, we can see your screen now.
Okay, if you guys are ready, I can start.
Okay, you can start.
Okay, thank you. It's really my pleasure to be here with our friends from Yemen and from various friends from WFNS Spine Committee. My dear friend Victor is here as well, and it's pleasure to be in a webinar with Victor. He's a giant of a neurosurgeon with a lot of effort in spine. We at WFNS Spine Committee did a lot of recommendations for the world for what we should do. So we for various kind of recommendations we perform. And during that time, we also looked at lumbar spinal stenosis and see what is the best way of treating lumbar spinal stenosis. Well, again, I'd like to thank my colleagues who have been here and the Yemen's Neurosurgical Society for hosting us. And it's our pleasure to be here. Pakistan is a beautiful city, and here we are. You know, this is one of the plains up in north of Pakistan. Of the top 10 peaks in the world, 6 are in Pakistan. It's an amazing place. And, you know, this is one of those mountain areas where they have this lake at a very high level and amazing views and huge opportunities to track. Well, let's talk about first pathology of stenosis of lumbar spine. Sorry, can we all mute ourselves so that it's easier?
Please, everyone mute your microphones so we can hear you.
Yemeni Dentistry Society.
Koji, mute your microphone. Okay, Dr. Salman, you can start now.
Okay, thank you. Pathology really is associated with facet hypertrophy, ligamentous hypertrophy, and collapsed disc. And the combination of these factors lead to symptoms that cause lumbar spinal stenosis. So the question is there rationale to intervene? Can we, by decompression, improve function? And we know that, yes, that the majority of the patients who have problems because of stenosis and have had failed conservative treatment, the way forward is decompression in majority of these cases. Do you really need to restore sagittal balance when we are doing this? Do we need to address listhesis if you have spondylo or retrolisthesis? Would you like to have beautiful x-rays afterwards, or would you like a patient who's asymptomatic with minimum possible intervention? So I think all these factors are important for us to address. Well, all the systemic reviews that were done until 2018 had shown that in majority of the cases, there was no difference in outcome between fusion versus non-fusion. So if you look at this meta-analysis in which they look at these 5 randomized controlled trials and they look at their study design, so majority of these have really, the numbers are really, really low. Whereas this study from FORCE was just from one country in which they looked at 233 patients, and you know the intervention, what kind of intervention they had, and follow-up duration. If you take majority of these were a 5-year duration, and they looked at various kind of scales. So looked at satisfactory rate, pain in back, etc. back in 1991, and graph from 95. Obviously looked at the VAS score, the walking ability, operating time, blood loss, complications, reoperations, and looking at the low back pain score, whereas the two studies that were published in same journal in 2016 from Gogowala and Forst showed that in one study with 66 patients, they looked at SF36 ODI score, blood loss, hospital stay, operating time, and showed that there was improvement in patients in which there was instability and they had fusion versus only decompression. Whereas all the other studies showed that there was no difference in outcome in patients with decompression or fusion. Well, if you look at the Gogowala study, this was a very well-designed study. So they looked at multiple smaller trials, demonstrated benefit for fusion in patients with spondylolisthesis. Gogowala did this prospective randomized trial along with Ed Benzo, and they compared patients with decompression alone or decompression with fusion, and they were small numbers. And they published a similarly designed trial demonstrating no benefit for fusion over decompression. Whereas, so both studies have nearly equal kind of patients, equal kind of treatment, but the outcome are completely different in these two studies. Clearly, the problem could be that obviously Gogowala was doing this all in the US, whereas Forst was doing all of these in Europe. So there may be difference in type of patients, difference in seniority of the consultants who were doing these, and difference in the equipment available to them. So that's a possibility, and bias could be there because of that. So Weinstein looked at the same, that surgery versus non-surgical treatment for lumbar degenerative spondylolisthesis. And they looked at both retrospective and prospective trials, indicating that patients with stenosis due to spondylolisthesis have better outcome with fusion than with decompression alone. The spondylolisthesis arm of the SPORT trial represents a large cohort of patients undergoing surgery and conservative treatment, and they had 600 patients in this. That trial found a benefit for surgery in patients with stenosis and listhesis. The important thing to remember, the 95% of patients in SPORT trial underwent fusion procedures, 75% were instrumented fusion, and so some of these were non-instrumented fusions as well. So you're talking about different kind of cohort that they were using in this particular study. And they showed improved outcome, which were maintained from 4 to 8 years. This trial was really complicated by heterogeneity in both the patient characteristics and surgical technique. And that's what we are concerned about this SPORT trial as well, that is this really true or not? So we look at this review article in which they looked at the SPORT trial and described the description, and the evidence was only class 2, and it was randomized. The numbers were pretty good and was observational. And they looked at patients with lumbar spondylolisthesis versus conservative treatment. And they showed surgery was better in each outcome measure at 2, 4, and 8 years. Gogowala, again, a very well-designed study, class 1 study, 66 patients, grade 1 spondylolisthesis, randomized to decompression versus decompression and fusion. And they showed that decompression and fusion significantly improved quality of life at 4 years outcome. Forst in the same journal showed that 247 patients, 135 with spondylolisthesis randomized to decompression with fusion versus decompression alone. And they found no difference in ODI or 6-minute walk test or at 2 and 5 year follow-up. So basically in this big study, they did not show any improvement. So back in 2009, did a systemic review of 24 text articles of surgery versus conservative for low back pain and lumbar spondylolisthesis, and found surgery equivalent to intense rehabilitation program. So there may be a group of patients who just require intense rehab and may improve as much as you can have improvement with surgery. That's why the conservative arm is very important when we see these patients, and we know patients should be subjected to early surgery unless there are red flags which are present. So the conclusions were from these studies were the 5 randomized controlled trials, including 438 patients, showed there was no significant difference between the 2 surgical procedures, so fusion versus non-fusion, in lumbar spinal stenosis at baseline and at 2 years follow-up. And these include half of these patients were spondylolisthesis. So this is a low quality evidence of the meta-analysis, and there's a lot of heterogeneity of various kinds of studies available. So factors that have not been studied up till now. Risks for selecting patients who may have failure after decompression alone. So what patients would that be in which we think that if we operate, we may not have a good outcome in these patients? So those patients may include patients who have facet angle more than 50 degrees, because 40% of these patients have a reoperation rate. Disc height more than 6.5 millimeter, if it's there, it was associated with 45% rate of reoperation. Motion at smaller listhesis more than 1.25 millimeter is associated with half of these patients with reoperation. Patients with at least 3 risk factors for these instability have about 3/4 of these patients required reoperation. Patients who had no risk factors for instability had 0% of reoperation. So this was a very, very nice study which showed that there are certain risk factors if you look at it, and then we can decide on these bases, should we fuse or just decompress these patients. What about facet joint orientation and tropism? Studies with a very low quality evidence have suggested that increased sagittal orientation of the facet joints is associated with progressive lumbar spinal stenosis with listhesis. While sagittally oriented facet joints have been associated with this, their role in the development of the disease, and especially in the stability of a disease segment, is controversial. So really, we don't have an answer to this clear-cut answer. So if you look at this patient with type 1 listhesis at 4-5, you see the signs of re-stabilization with disc height loss, with stable slip, and at the same time, you see lack of facet joint effusion. So there's no effusion that's seen here. So what about effusion? Is there any correlation with the degree of instability at a segment? And would that, by fusing that, we would improve the outcome or not? So several people have proposed that unvalidated calculation techniques exist for measuring facet joint fluid effusion. Low to very low quality of evidence. Presence of facet joint effusion best seen on supine axial MRI appears to have a linear correlation with instability. So anytime you're looking at effusion, you need to look at supine axial MRI and not in any way an erect MRI, which many people perform in the Western countries. What about these re-stabilization signs? Actually, there is no firm agreement on what parameters indicate a re-stabilization of segments. So few we just talked about over there, but osteophyte formation, vertebral end plate sclerosis, and ligament ossification have been implicated in the process by very low quality evidence. So there's not good evidence that's available here. So if you look at this particular thing in which you can see facet joint effusion, you can see there is osteophyte formation on top of it. So you've got this effusion and a stable slip in these patients. So facet joint effusion, obviously, you need to look at re-stabilization signs, disc height loss, we have talked about it. Changes in disc angle or flexion radiographs, there's a very low quality evidence in all these. And then leg dominant versus back dominant pain. Again, we are not sure that if we operate on people who have got back pain, we really are going to improve the symptoms in these patients. So this study actually looked at 3 types of instability. So in type 1, it was stable, none, or very mild. Re-stabilization signs, grossly narrow disc height, disc angle, lordotic disc angle on flexion radiographs or less than 3 millimeter of translation or dynamic films. Joint effusion, if there was no facet joint effusion. So somebody with all these normal obviously is stable. Whereas when you have got some back pain, you've got re-stabilization signs, reduced disc height, and neutral disc angle on flexion radiographs along with facet joint effusion on MRI. Whereas if you've got completely unstable patient, then you can think about all these qualities. You will end up maybe improving these patients, and fusion may be the best thing over here. So you can have decompression or posterior fusion. In type 2, potentially unstable. In 3, you need to have fusion, decompression, and ideally an interbody fusion of some kind. So this fusion algorithm was proposed by our friend Simmons, and many people use this as a routine. So questions that need answering: patient with stenosis, no signs, symptoms of instability, predominant leg pain. Obviously, decompression alone is recommended. Available evidence is there, which is moderate to high. And there are at least 2 good quality randomized controlled studies which have shown that this is very effective and does work. So we do have an answer regarding this, that yes, if you have no signs, symptoms of instability and predominantly leg pain, decompression alone is enough. Patients with stenosis, with stable spondylolisthesis. The degenerative process of the spine is usually divided into 3 phases. We know this: inflammatory, instability, and restabilization, as we had seen earlier. Fusion will not help. Decompression alone is suggested. So these are the patients who are in their 60s and 70s, and there's not much movement because they've restabilized eventually. And there is available literature which is moderate. And we have an answer that yes, probably decompression alone may be just the best thing to do here. How about unstable spondylolisthesis with symptoms? Obviously, significant disc space and instability on dynamic view. There is more than 5 mm displacement or 10 to 15 degrees of rotation on lateral flexion extension lumbosacral radiographs, and they have to be standing, or 25% or more slippage may require fusion. So these are the factors on those bases that we think that fusion is essential in these patients. Again, I'll go back. Dynamic views, more than 5 mm displacement, more than 10 to 15 degree rotation on lateral standing flexion films, and 25 degree or more slippage may require fusion if they have symptoms. Available evidence, again, is low. So do we fuse? Probably yes, but again, it's controversial. You think you cannot, if you have got minimum complications, then you should think about fusing these patients. But again, if you think that your complication rate is high or facilities are not as great, then you can just think about decompression alone. What about these patients in which mechanical back pain is more than leg pain? And this is suggestive of symptomatic listhesis, and fusion may be beneficial. Again, this is our hunch when we see these patients who are coming back again and again. You've tried conservative treatment, you've tried injection therapy, you have tried local blockage, you have ensured that you've ruled out sacroiliac joint or other arthropathies, then yes, fusion would be applied. But again, the evidence is low, and it is a controversial topic, and many people would argue that it may not be required. What about stable listhesis with deformity and loss of balance? So if you are symptomatic, you may necessitate correction of underlying deformity with decompression and instrumented fusion, and at the same time correction of the loss of balance at the same time. And these we know with corrective osteotomies can result in good outcome. Again, this paper recently in 2019 showed that if you improve the sagittal alignment assessment and you look at it beforehand for short segment lumbar fusion for this disease, then you can improve outcome in these patients. So they looked at these 419 patients. Of those, 32 represented pseudoarthrosis, and about 6% of these symptomatic ASDs, and rest of them showed evidence of uncomplicated fusion, which was a control group. So they looked at standard spinopelvic parameters and they measured them, and difference of the values within the parameters are also calculated. A comparative analysis within and among groups were performed, and patients are analyzed by cage characteristics, large or small, titanium and what they showed that age, size, and type of the cage was not related to fusion, non-fusion, or adjacent segment disease. They also showed that patients in the non-union group represent greater problem with the sagittal balance before and after surgery, the greater PI, LL after surgery, and higher PI, while ASD patients represent greater absolute mean values. So they concluded that central alignment in the preoperative setting, even when treating patients with short segment lumbar fusion, you should be thinking about what kind of cage you would put in, how much correction you would do. So you would plan this beforehand, and then you can give reasonably good results in these patients. So is fusion necessary to correct curvature and deformity? Role of fusion, yes. Again, what is the evidence? Literature for deformity with listhesis, the evidence is low. And again, fusion remains controversial. What about facet joint effusions? So we talked about that if you have facet joint effusion, what do we do? So patients who underwent bilateral facetectomy or 1/3 or half of that is excised more than during 50% of pars interarticularis, bilateral discectomy in addition to partial facetectomy, spinal fusion may be advisable. So that's what suggested that if we are giving instability by taking bilateral facets, maybe 1/3 or half of them, and there is you're excising the pars, 50% of it, then you should be thinking about fusing, because you are already creating a disease which we think can be symptomatic afterwards. Again, the evidence is low to medium, and the role is again controversial. So there is, if you see, majority of these studies do not really show what is the best way forward. So facet joint effusion alone is not proven to correlate with instability, and the available literature is again low, and fusion is not recommended just on the basis of facet joint effusion. So if you've got multiple factors, you can think about fusing these patients, but not facet joint effusion on its own, and especially if it's asymptomatic. So this a particular study looked at critical analysis of trends in lumbar fusion for degenerative disorders, and they looked at influence of fusion and clinical outcome. So they did a systematic review between 2000 and 2015, and about 8,500 patients and 160 studies were taken. PLIF and TLIF had significantly higher fusion rate compared to instrumented posterior lateral fusion. Clinical success rate was statistically higher with MIS versus non-MIS fusion. So this clearly shows that MIS surgery may be beneficial in these patients in line of clinical success rate. That includes reoperation rate, as well as early mobility and less requirement of narcotics, and obviously better cosmetic results. Lumbar fusion from degenerative disorders 2000-2015 demonstrated a trend towards more antibody fusion MIS techniques in the past decade, and now recently it's gone even way ahead. Clinical success with MIS appears more likely than with non-MIS fusion, despite equivalent fusion and complication rates. Further high-quality comparative studies may be required. So what were the recommendations from the World Federation of Neurological Societies regarding lumbar spinal stenosis? Surgical decompression is an effective option in patients with moderate to severe symptoms. There is no consensus whether microscopic techniques are equal to a standard laminectomy to achieve adequate spinal canal decompression. We know that bigger incisions, too much of dissection will lead to adjacent segment disease and will lead to more pain afterwards, back to persistent pain for some time. To be careful just doing a standard laminectomy in majority of these patients, unless they've got grade 3 or grade 4 stenosis. There is no consensus whether unilateral laminotomy or bilateral decompression or bilateral laminotomy are not inferior to standard laminectomy for treatment of lumbar spinal stenosis. Since nobody routinely does this anymore, so it's very difficult to do a trial among these. So there are no good quality studies available, and data is of very limited numbers. MIS has some advantages over open decompression for early clinical outcome, blood loss, wound pain, infection, and hospital stay. And that may be very, very valid in our part of the world. So if you look at MIS is associated with lower complication rates than an open approach. There is no consensus if MIS is more cost-effective than a open laminectomy. There is no consensus for overall complication rate and reoperation rate for lumbar decompressive surgery. Cardiopulmonary complications stroke in these elderly population occur in about 2% and mortality in 0.5%. New neurological injuries and post-operative hematoma after decompression are rare and less than 1% of these cases. Incidental durotomy, unfortunately, in majority of the series are almost up to 10% and depends on established risk factors and has only minor effect on outcome. And we know this. And if you look at in patients with lumbar spinal stenosis and no signs or symptoms of instability and predominant leg pain, decompression alone is recommended. In patients with stenosis and stable spondylolisthesis, fusion is not mandatory and decompression alone is suggested. Unstable spondylolisthesis with symptoms may require fusion. There is no consensus if the main complaint is mechanical axial low back pain more than leg pain, the patient may benefit from a fusion surgery, as we had discussed before. Patients with lumbar spinal stenosis and loss of sagittal balance, if symptomatic, may benefit from decompression, fixation, and deformity correction at the same time. In patients who underwent bilateral facetectomy more than 50% and bilateral discectomy, fusion may be advisable. We say advisable because in many times, if you're happy that patient still is stable, you may not need to do that. But if you think you have taken out bilateral facets more than 50%, you should consider this. Facet joint fusion alone is not proven to correlate with stability. So these are the guidelines from WFNS Spine Committee. It's a pleasure to be with you.
Professor Salman, thank you very much for your valuable lecture. And anyone have a question? We'll start discussion now. Dr. Majid.
I'd just like to ask you about the stable spondylolisthesis. You said that there is no role for fusion in such cases. What we have increased instance of for further spondylolisthesis, for further progression of the split or progression of the spondylolisthesis if we do not do fusion from the first surgery, if we consider to do just fusion without just decompression without fusion. Is there any liability for progression of the spondylolisthesis to the second or third degree?
Sure, that's what we said, that if you have characteristics of instability on flexion extension standing films, and if you do see a problem and patient is symptomatic, then you should fuse. Whereas on the other hand, if you don't have those problems, we talked about the movement that's there, we talked about the angulation that's there, we talked about the changes in the joints itself, and we talked about back pain more than leg pain. So if you have those, then you could consider fusion, but at the same time, there is no evidence in literature that makes fusion superior in stable spondylolisthesis versus non-fusion. And the number of patients who require reoperation are obviously more with decompression compared to fusion, but we know that the complication rate is high with the fusion versus just the decompression surgery. So we need to balance that, and there is no evidence in literature that yes, fusion in every case of grade 2, grade 3 spondylolisthesis will result to a good outcome.
Thank you very much. Thank you very much. Any more questions?
Any more questions? Thank you, Professor Salman. And it is the first time for us, so we have some problems, but we will look out to prevent this problem in the future. And thank you for your valuable information and valuable lecture.
I'm grateful, and it's really my pleasure to be part of the Yemeni Neurosurgical Society. And on behalf of the WFNS Spine Committee, actually I'm the chairman for the Spine Committee at the moment and also the president for World Spinal Column Society. So on behalf of both these societies, and Professor Victor Hugo is here. He's also a co-director of one of our emerging anatomy societies on spine. So we'd be happy to help and cooperate and guide you in any way we can.
Thank you very much, and it's an honor for us to have you with us.
It's a pleasure.
Thank you very much.
Thank you, everyone. The link is already in the chat for everyone who need continuous medical education certificate. Please fill the link on the chat, okay? And thank you, everyone, for your participation and joining our first webinar. Thank you,
Thank you.
Doctor.
Bye-bye. Thank you.
much.
Bye-bye.
Thank you very much.
Thank you, everyone. Dr. Victor, thank you very much for your participation.
Thank you. Thank
Thank
you so
you.
much.
Thank you. Salam alaikum.
Thanks to everybody.
Victor, how are you?
Hello, Said Taha. Very nice
How
to
are
see
you?
you here.
Yeah, thank you very much. It's a great pleasure to see you. Happy New Year. Happy New Year.
Happy New Year. Yeah,
Yes,
for all of you.
thank you.
Thank you so much.
To Professor Salman and our friends of Yemen. It's
Yeah,
very interesting. Thank you very much.
thank you. Thank you. Thank you, Dr. Ahmed. Thank you, Dr. Ahmed.
Salam, thank you. Salam alaikum.
Salam alaikum.
Thank you, everyone.
Shukriya.
Post the link
Salam.
in the chat, okay?
To all Yemenis neurosurgeons, salam alaikum.
Thank you, everyone. Thank you, everyone.
Thank you.
Thank you. Bye.